Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for joining us. In this broadcast we're going to take a look at chlamydia. But before we begin, here's a quick word from Belinda Bailey about Rural Health West's Doctor Service Awards.
Hi everyone and welcome to another Rural Health West Rural Doctors broadcast. I just wanted to take a moment to congratulate and acknowledge all of those doctors who are at the recent Rural Health West annual conference who received an annual Long Service Award. The Rural Health West Long Service Awards have been going on for 6 years now, and we've presented 160 awards to doctors who have spent 20 to 30 years practicing medicine in country Western Australia. It's a fantastic day, a fantastic event, and there's nothing actually quite as heartwarming as seeing peers recognise peers for the wonderful work that you all do out there in rural Western Australia. So to all of those doctors that received an award, a huge congratulations. We also give out 5 special awards, and they fall into categories for all sorts of things like amazing contributions and long-term outreach services and remote and clinically challenging medicine. And to all of those doctors that received one of those awards, a big congratulations to you too. Of course, you know, you all deserve an award, and there's no one more than Rural Health West that absolutely appreciates and understands the work that you do and how much you all deserve an award. So thank you from all of us at Rural Health West for the great work that you do. The special awards, the 5 categories, will be available for nomination again in the next month or so for 2014, and I'm sure that you probably know someone who's deserving of one of those awards. So I'd really encourage you to keep an eye on the website, download a nomination form, it's quick and easy, and nominate someone that you know who's really deserving.
Thank you, Belinda. Now let's get started. Joining us today is sexual health physician Dr. Jenny McCloskey. She spoke with Dr. Olga Ward about a worrying increase in the prevalence of chlamydia and some other sexual diseases across much of Western Australia.
Jenny, welcome to the program.
Thank you very much for inviting me.
Jenny, chlamydia is a really well-known disease, but I think sometimes it sneaks up on doctors and patients. Could you maybe talk us through the ways that chlamydia might present, and are there any times when even you've been caught by surprise with it?
I think the most common time I get caught by surprise is women who have spotting in between their periods, and we find chlamydia incidentally in that. They've often been thought to have breakthrough bleeding with the oral contraceptive pill. I think when you do routine pap smears and do chlamydia, then you'll find it much more often than we normally would. And the one that probably surprises me is the amount of asymptomatic chlamydia in the men who have sex with men. And we recently did a study at the clinic looking at chlamydia as well, and we found amongst heterosexuals there was much more chlamydia in the throat than we actually expected. That was a real surprise for us. And just to remember that, you know, every orifice is a sexual organ, so you've got to remember, you've got to know the sexuality of your patient. Not all patients are heterosexual. They may not have told you that they have male partners, that the mouth is used for sex by both heterosexuals and men who have sex with men, and then some men have anal sex. And the other thing people think about anal sex too is they think there has to have been anal penetration, but we actually see a lot of infection, I think, that's transmitted by hands, the secretions. So you can actually get transmission of chlamydia and gonorrhea and warts just by hand transmission, the finger stimulating the anal canal. So that's how the infection can occur. But chlamydia's got a predilection for columnar epithelium. So that means the endocervical columnar epithelium, and in the throat, that's the tonsils. So if you want to do a good swab of the throat, you actually swab both tonsils and the posterior pharynx to get a good swab.
Well, Jenny, I'm sure I'm seeing more cases of chlamydia in the last couple of years, and I've just turned up 3 in the last week, which was a bit of a shock for me. Is the prevalence of chlamydia on the rise, or is it just that we've got a easier to do test, therefore we're picking it up more?
The data, certainly in Western Australia, shows that it's increasing in both men and women. And a similar pattern has actually been shown in other countries overseas, and we have this extraordinary paradox. The more we diagnose, the more we treat, the more the rates of chlamydia actually go up. And people have tried to explain why that actually is happening. And one of the reasons where they think that might be happening is if you don't treat it, then there's a low level of immunity to reinfection, and so you're not picking up the repeat infections. It's just constantly there. But if you actually...
So these are people who are asymptomatic carriers, but they're spreading it around? Is that what you're talking about?
Yes, asymptomatic carriers and spreading it around. And also there's been some really good research to show that if people have chlamydia, they seem to be more prone to acquiring it again. So whether it's the network or whether it's their age group, it's mainly boys and girls under the age of 25 who have it. And a lot of the time it's asymptomatic. And yeah, it's a really significant problem. We're concerned about the consequences such as infertility that may occur in this age group.
Yeah. Well, we used to have to do endocervical swabs and urethral swabs, which were, you know, a really definite put off for the patients. But how good is the first stream urine and the low vaginal swab at actually picking it up?
They're very good. The molecular testing now with the PCR can pick up very low numbers of organisms, so they're very good ways of testing. But in women, we would be wanting to do a urine, a first void urine, and a low or high vaginal swab. Remember, the infection's coming from the endocervix, so yeah, as long as the patient doesn't hurt themselves, a vaginal swab is a good thing to do.
In your average teenagers, teens and early 20s who seem to go through partners, I think perhaps even more than they used to, how frequently would you recommend testing?
Good question. Certainly every time a female has a pap smear and that's every 2 years, but in the young age group it probably depends on the number of partners. So if people are having you know, a frequent partner change, then I'd say every 3 months or every time they change their partner. But that might be too often. It might be every couple of days for some people, and that's just unreasonable. But generally we'd say every time you have a new partner, get yourself tested. And if people are really having a lot of partners, like in the gay community, we would be recommending regular 3-monthly testing. And we're looking particularly also for syphilis in that community as well.
Now what about sex workers, Jenny? I know they all say, oh, I use a condom all the time, every time, but how often do you screen sex workers? And I presume you screen them for everything you can screen them for, yeah?
There's some really interesting data about sex workers, and that's the sex workers who've been in the industry for a long time tend not to get their infections. So the infections are in young girls entering the industry where they're probably not immune to any of the infections and possibly take greater risks and are possibly not using condoms. But if condoms are used, there's great data coming out of Sydney that show these women just don't have the infections. And the risk for the sex workers is actually coming from their partners. Their partners are having other partners outside the relationship because they know their girlfriend is a sex worker and they're infecting the girlfriend that way. So every time they have a broken condom, they should be tested, and our clinic policy is that they need bloods done every 3 months to look for HIV and syphilis. We need to make sure they're immune to hepatitis B, vaccinated, and then we do genital swabs every 6 weeks. But if they're using condoms, then the likelihood of picking up infections is actually quite low in this group based out of the Sydney group.
And you were saying earlier that the sex workers had some danger from their own partners straying around and not using condoms.
It's a really significant risk for the sex workers. And the other comment that I actually need to make about sex workers is we see a lot of our patients coming to us who've actually had sex with sex workers in Asian countries. And condoms may not have been used in that group, and there's a huge risk of HIV coming from this population group. And we're actually seeing HIV amongst the fly-in, fly-out workers, and it's also being reported up in Cairns now that they're seeing the people who are cashed up lots of money, going on overseas holidays, picking up a girlfriend overseas or having sex with the sex workers. The heterosexuals are now coming back with HIV infection. And in Australia now, or Western Australia, we have one of the highest rates of HIV acquisition, and last year we had 123 new cases, and half of those were actually heterosexuals. So it's not only an infection now that infects men with men, but it affects men who have sex with women and women who have sex with men.
Where are the tourists mostly picking up the infections? We're talking about Thailand and Southeast Asia mostly?
All of those countries, Bali, Indonesia, India, and again you need to be aware of the migrants who are going back to Africa. So it's all those countries that are known to have very high rates of HIV, all of those countries. And China.
When we're giving people travel advice, that should be part of just the standard travel advice, yeah?
Always use a condom.
Always use a condom.
And condoms are really good if they're used properly at stopping acquisition of HIV. I mean, basically to catch HIV, it has to be placed inside your body. So if you cover yourself with a condom, then the risk is it's virtually eliminated. Though people, again, in the gay community, they're tending not to use condoms for oral sex, and so we see a lot of gonorrhea and chlamydia of the throat, and we're seeing syphilis now. And that's the one thing about condoms, it doesn't stop skin-to-skin spread, which is syphilis, and we've have an ongoing sustained epidemic of syphilis amongst the gay population in Perth, and similarly they have sustained populations of infection in Melbourne and Sydney at the moment as well.
Speaking of blokes, girls reasonably easy to screen if they're turning up for a pap smear. I guess being a venereologist, you get the referrals, so the person's already been kind of filtered. But what's your best approach line for talking about STI screening for young blokes?
Well, in the clinic, they expect a really thorough examination. So, in fact, we double sample, which is unusual, but we found that if we do both a urethral swab and a first void urine, that we get a 5% increased pickup rate. We're actually going to re-examine that data to make sure that that's still valid for the population at the moment, but that's what we found. But I think in general practice, just the first void urine is an excellent way of screening. But if people have symptoms, we want to do cultures, and we know that gonorrhea is resistant a lot of the time, and it's doomsday for gonorrhea. At all the international meetings now, they're having forums now about how they expect gonorrhea to be virtually untreatable within the next 10 years. There's at least 2 reports of ceftriaxone resistance. The first one was in a sex worker in Japan, and there's also reports of ceftriaxone resistance being diagnosed in France and Spain. So there's pockets in Europe. And we're scratching our heads now with what we need to treat gonorrhea with. But how that pans out into the WA community is we're seriously concerned at the moment because there's not enough data on the types of the antibiotic resistance data in the population. So, because everyone's just doing urine tests or PCR tests, we actually don't know if these highly resistant strains of gonorrhea are entering Australia. And we need to, I mean, this is a real beg and plead now, is to make sure if you have gonorrhea, a patient with gonorrhea, that we get cultures so that antibiotic sensitivity can be undertaken.
Now, chlamydia hasn't shown this same kind of resistance pattern, has it? So if you, say, are in general practice and you're trying to approach, you know, Joe Bloggs, who's come off the street and has told you in passing about the wonderful holiday he's just enjoyed in Thailand and Vietnam and how he picked up a couple of chicks, you might say, wouldn't be a bad idea to do some STI testing. If you, in the first instance, to decrease the threat, did that first void urine and it came back positive, that's quite legit then to get the patient back and do the swabs before you actually treat.
I think that's a really important thing to do. If it came back, so you're saying it came back positive for
so
gonorrhea?
you do the first void urine, and that's just like your population screen. It's non-threatening. You know, go and pee in a pot is much less threatening than drop your ducks and I'll just kind of come at you with this big swab. But I think once they've actually got a diagnosis, then you would recommend doing some swabs so that we can work out the antibiotic resistance and then give them the standard treatment.
Well, the standard treatment's just about to change.
Okay, so for chlamydia it's still azithromycin.
Azithromycin 1 gram. And now, because of this huge concern about the evolving resistance of gonorrhea, we now use 500 milligrams of ceftriaxone.
As an IM injection?
IM injection. And now the Silver Book guidelines are being changed to include a gram of azithromycin. So they think that by combining ceftriaxone and azithromycin together for gonorrhea, they may stave off the evolution of the resistance that's going to occur. Whether that'll happen or not, we don't know, but the public health physicians think that it may give us a little bit of more time before we've got our backs against the wall.
Now, we used to give 3 grams of amoxicillin and 2 grams of probenecid, you know, down the hatch while you watch them swallow it. How much good would that do these days? I'm talking just like over the last 15 years. How much has the resistance increased?
Still works in the Kimberley.
Yeah.
But we don't know that that actually eradicates the throat infection satisfactorily or the rectal infection. So again, in the Kimberley, I'd love to see more throat and rectal swabs to know that oral medications work, but certainly it's sensitive. But we just know we have more treatment failures with throat and rectal swabs, which is, you know, why we need to test those sites and also know the antibiotic sensitivity.
Sure. And Jenny, earlier you were talking about chlamydia and fertility problems. And again, those kind of long-term fertility problems in women who've been infected with chlamydia and haven't known about it until they start to get pregnant, that's kind of in most of our consciousness. How much infertility in men does chlamydia cause? Like if you're investigating a couple for infertility, would you test both of them?
Well, I'm not actually involved with infertility testing, so I'd have to defer that question to my colleagues. But I mean, if you've got one partner that's infertile and you're testing chlamydia, it makes sense that you test the other partner, and I know that they routinely do that.
Yeah. But you don't know whether chlamydial epididymitis, for instance, kind of gums up the whole works?
It's thought not to be as common as the consequences in women, but what proportion? Again, worldwide, everyone's looking at infertility, and they actually think that maybe it's not as serious as we thought it was. So it's a work in progress at the moment, but we do know there is a link.
Yep.
We also know that if you have pelvic inflammatory disease, and this data is indisputable, and you get one infection, you do have a risk of infertility, but if you get it a second time, your chance of infertility doubles, and you have it a third time, it increases again. And so it really means it's so important for contact tracing to occur. So you diagnose someone with chlamydia, they've got PID. These people, you've got to make sure they don't go home and catch it again from their partner, that their partner's actually been treated before they get out of hospital. And I think that's one area where, as doctors, we sometimes fall down, particularly in hospital. I think there seems to be a problem with communication and resources really for the contact tracing that's required in that sort of scenario.
Yeah, well, I mean, as a GP in a small country town, the information goes round and round in the town regardless of how well you try to suppress it as coming out of the surgery. Obviously, I could ring Jill Blogs and say that I have reason to believe that you've had contact from chlamydia and she knows she's only been sleeping with Joe. You know, it's going to go round the town, isn't it? Are there any kind of external resources you can use for contact tracing that might be a little more anonymous than a call from the GP surgery in a little country town?
There's some really good digital age technology resources now. So there's two websites available. One is couldihaveit.com, and that's for both doctors and also for patients. So there's a form that can be downloaded by the doctor so they can give a form saying you've been in contact with chlamydia for the patient to give to their contact if they don't want to ring them themselves. And also there's a way that patients can actually get their own mail order kit off this site as well. So if they're too embarrassed to go into the doctor for some reason, then they can do their own testing that way and get the... But then they will have to present to a medical person for treatment if they're found to have it. So they test themselves, but it still has to go into a laboratory. So they
do a first stream urine or a swab.
Yeah.
Do they then have to, do they just post it?
They have to take it into a laboratory. So there is some loss of anonymity there, but at least it's a bit more discreet, I think. And the other website you mentioned is a really good one if people want guidelines on how to SMS the fact that they've been in contact. So there's some guidelines there on how to go about, you know, passing that message on. And these days, as you know, everyone seems to just send messages rather than face-to-face contact, and that's a
Although
good way
I can
of doing
just
things.
imagine getting, you know, 3 text messages and one of them says Mars is having a sale and one of them says, by the way, you might have chlamydia. Could be a little bit disconcerting.
Though these days, I think the younger population's much more open about talking about their sexuality, and they're curious. So I think that the resistance that we had from our age group seems to have gone. So I don't think they are so concerned anymore. And they'd rather know, is my impression of the younger age group.
Yeah.
And we'll return to that discussion in a moment. There are still significant differences in the prevalence of some sexually transmitted diseases and in the best practice management of sexual health between gay, lesbian and transgender communities and the broader population. We spoke to GP Dr. Terry Pitsakis about providing better sexual health to gay, lesbian and transgender people and how to approach the topic of sexual practices with your patients.
Terry, there are differences between providing good sexual health care to the broader population and to gay and lesbian and transgender communities. Can you talk us through some of the issues from your point of view?
I think the first issue is recognition of your patient's sexuality. I think that's really important. Percentage-wise, 6% in a study done several years ago, 6% of men would have had sex with another man in the previous 12 months, and 3% of women in Australia would have had sex with a female partner in the previous 12 months. Of those, more than half would identify as being homosexual or gay or lesbian. So is it important to you to find out the sexuality of your partner, of your patients or not? And that's really the issue that we need to focus on. It seems obvious to me that it is important, and on most programs, most software, you'll find that there is a segment which asks for the identification of your patient's sexuality. I try and get all my patients in this practice to have that box filled so that we know their sexuality, because it's important to know about their sexuality, their sexual experiences, their health issues that arise from that, and also the other mental problems such as depression and family issues that could be a consequence of their sexuality. How do you do it?
Yeah.
That's the big question. It's a routine in this practice to ask that specific question. We ask their marital status, we ask their relationships, we ask their recent sexual partners, and we get that information. And from there we then talk about sexual health needs, we talk about any investigations they would want, whether they want a sexual screen or not. We might not do it on the first time they visit, but certainly the second or third time when it's evident that they're coming to this practice, we would do it. Now this practice is gay aware, it's gay friendly, it's in Mount Lawley, it's known as a really good practice to come to if you're gay or lesbian, and that your health issues will be discussed, there will be no discrimination, and that you'll be welcome into the practice. Now,
so a lot of your patients may well come in expecting to be talking about that as part of their health history.
Yeah, they will be. In country practices, you'll find that those numbers are much less because people gravitate towards the city. And in fact, Perth people, when they're dealing with their sexuality issues, in the past anyway, in their early 20s, would go to Sydney or Melbourne or a bigger city where they could deal with that sexual issue. Sexuality, the gay lifestyle is becoming more accepted by mainstream population, so there's less reason for Perth kids to want to go elsewhere to come out. However, country people will still find discrimination and will be very reluctant to tell their old GPs or tell their care providers their sexuality issues because they don't want it known throughout the rest of the community. And that's because of the negative feelings coming from the rest of the population or even from their families. So there is still quite a lot of discrimination against gay people and lesbian people and transgender people as well.
So then how does a GP start to broach the subject in a way that is clear to that patient that it will be treated with confidentiality and it is an important part of their overall health?
Well, you never know who's gay and who's not gay, and you'll be pretty surprised if you do start asking the question. But it's important to ask the question at some stage. If a person comes in and requests a sexual health screen, then it's mandatory to ask what their sexual practices are and also to ask their sexuality issue. They even may be married, but if they're coming in for a sexual health screen, then obviously they've played up or they're worried about some interaction they've had in the past or even in the present. So you need to ask almost every patient who comes in at some stage issues about their sexuality and their attraction to females or males or people of the same or opposite sex. So that's got to be a standard question somehow. Is it easy? No, it's not, and you may find anxiety when you're asking patients that question. Anxiety because you're afraid that they may be offended by the question, or your own anxiety because maybe you have issues around your own attitude towards people whose sexuality may not be heterosexual. So you've got to come to grips with those sort of problems as well. But once you've done that, once you've broached the subject, then you can then help the patient a lot more than by knowing their sexuality than by not knowing it. So you've got the patient coming in, you find out their sexuality issues or that they're identifying as being gay. What would you do with that? Well, the simple thing is to see how comfortable they are with it, to see if they're coping in your country town, whether they've got any problems in their family dynamic around their sexuality or discrimination in their workplace. But the bigger things and the other things medically are exposure to disease. Now with lesbians it's actually less of a problem than even with heterosexual women, but certainly with a man who has sex with men, and they're not necessarily gay identified, so the modern term is MSM, which means a male who has sex with another male or men who have sex with men. With that group, then it's really important to ask a few questions around the sexual activity they may be having. But that probably goes with anybody who's coming in for a sexual health check. It's no point in doing just a vaginal swab if a woman's having anal intercourse as her way of contraception or her way of pleasure. So that's an important question generally. Most people will also engage in oral sex. So if we're not doing the oral swabs, if we're not taking a swab for MCNS, not doing a PCR for chlamydia and for gonorrhea, which most labs will do now, then we're missing out on the potential of having chlamydia in the throat or gonorrhea in the throat. So really, to ask these questions means that you know what investigations you're going to do.
Absolutely. Like so much of medicine, it's about getting a good history.
Yeah.
And then choosing your investigations appropriate to that history.
Yeah, that's right. Of course, I suppose I should mention as a sideline, if a patient comes in for something else and they're under 25 and they're sexually active and they're not in a monogamous relationship, then opportunistic screening, which is a simple self-obtained vaginal swab or a urine test for PCR for chlamydia and gonorrhea in a female, and a urine test for, again, PCR for chlamydia and gonorrhea in a male would be a pretty good idea to do. But if you find out that they're having sex with other men, or they're coming in specifically for a test, then they're not necessarily going to give you a lot more details about their sex life. They're probably not going to talk about exactly what sort of sexual activity they do, but they could give an indication that they have anal sex and oral sex. And really, that's really important that you know. So then you're going to not only do the urethral swab if they warrant that because they've got a discharge, but if they're asymptomatic, you'd probably just do a urine test, but make sure you do an anal swab, both for MCNS and a dry swab for PCR for chlamydia and gonorrhea, plus throat swabs, as I mentioned earlier. The blood tests are really important. You've really got to find out whether the patient's got HIV. So here's where the pre and post-test counselling comes in, and that depends on your time allocated to the patient, whether you're comfortable with talking about sex, whether you can talk to them about using condoms all the time, and you might want to brush up on that. The other test that you need to do is for hepatitis A and B. Hepatitis A is more common in men who have sex with men. That's related to analingus, or what is termed rimming by the community, and also hepatitis B is more common as well. So it's really important to immunise this group of people coming into your practice. The other big red flag is education, and that somehow the word about safe sex hasn't quite got to a lot of people, and there's a lot of unsafe sex going on in Western Australia at the moment. We're seeing that by the increasing rates of chlamydia and gonorrhea amongst this group, and also there's been a slight increase in the HIV amongst men who have sex with men, and a lot of younger guys are coming through as well. So that's where the other red flag is if you see somebody in your practice who you think, or rather tells you that their sexuality is with other men, it's a really great opportunity to talk about safe sex, get them comfortable, and tell them about using condoms for anal sex and that they need to protect themselves.
And our thanks to Dr. Terry Pitsakis for his time. Now let's return to our discussion with Dr. Jenny McCloskey and Dr. Olga Ward.
Now, I would usually check women, particularly women who aren't sort of in a long-term stable marriage or whatever, before I'm putting in an IUD, for instance. Are there any other situations where you sort of think, gosh, you know, almost mandatory to do the testing?
I think the IUD insertion is the mandatory one. I can't think of any other scenario, but you don't want to be putting an IUD into a woman who's got chlamydial infection. Now, there's actually an emerging pathogen that we're starting to learn about, and watch this space. We don't know yet. It's quite possible in the future, if we find this is a significant pathogen in women, we might recommend testing, but there's a new organism on the block called Mycoplasma genitalium, and there's a PCR test, which is an in-house test available from Path West, and you test the same sites in men and women that you test for chlamydia. But at the moment, the evidence is that it's a cause of urethritis in men, and we're a little bit confused at this stage as to how much it actually causes a problem in women. So there's some evidence that suggests it can cause a cervicitis and possibly PID, but the data is still being collected, but there's no doubt it causes about at least 40% of the cases of non-chlamydial urethritis. And that's great because we can identify it as a pathogen and we can treat it. But sexual health's not easy. You treat one thing and then you have another problem.
Yep.
And it looks like using azithromycin may be inducing drug resistance in this organism. And so if you find that someone's had NSU and you've treated them for chlamydia and they've still got ongoing problems, then we'd be recommending in men that you do the swab for Mycoplasma genitalium. And because they've still got the symptoms after you've treated them with the azithromycin, you've got to make the assumption probably they're drug resistant. We can't test in the laboratories here in Perth yet. And there's a 1.5 gram dose, so spread over 5 days. So it's 500 milligrams of azithromycin followed by 250, 250, 250, 250. But it's not PBS listed, which is a bit of a problem.
Quite often GPs will see women with quite chronic cervicitis or very persistent vaginal discharge, and you'll do swabs for chlamydia and they're negative, and the high vaginal and endocervical swabs, and they don't show anything in particular. If you do a swab for mycoplasma and ureaplasma, would you do that as a PCR or as a culture? And are they a infection or a commensal?
I'd be doing it as a PCR because they're terribly slow-growing organisms, and I'd only be requesting culture if I wanted to punish someone in the laboratory, and I don't think they'd even do it for me. So they're very, very slow-growing, so the test is a PCR. And I think that if a woman does have cervicitis or signs of pelvic inflammatory disease and it's not chlamydia, it's not gonorrhea and it's grumbling on, then you have to consider these organisms and treat for them. And 10% of your ureaplasmas are actually resistant to tetracycline, so then you have to go for other antibiotics such as clindamycin. But
that'd also go for your ladies who are not very tolerant of macrolides or doxycycline, wouldn't it?
Yeah, yeah.
So clindamycin's a good choice?
Yes.
What other sorts of choices have you got that aren't macrolide?
Mainly we would just use clindamycin as, would be the main one. We are now starting to use a lot more moxifloxacin. So we're using it for the new organism Mycoplasma genitalium. But we have restrictions on the use. It's not licensed outside.
GPs can give moxiflox as a private prescription, but it's not cheap.
No, it's about $70 a prescription, but there's interesting emerging data from overseas where they want to change PID guidelines and include that, but that hasn't happened yet. And I think we have to stick to the antibiotic guidelines that exist at the moment. So it's not a treatment that can be used really outside of the hospital setting. And even in the hospital, they're very concerned about antibiotic usage, so the stewardship. So we even have to ring our ID colleagues to get permission to use it.
And once you've treated, when do you actually do a test of cure?
That's a question that puzzles everyone. And
I'm always worried about PCRs kind of picking up a little bit of DNA that's still there at the end of 6 weeks or something, and the patient thinking they haven't been cured and putting them through another lot.
Our evidence, when we've looked at it in other centres, is that you can retest it 3 or 4 weeks. So there will be no non-viable organism there at 3 weeks. People tend to use 4 weeks, it seems to be easier. But then some people don't like having any tests at all. They don't like to come back for tests, and it depends, I think, on how compliant your patient is. And so some people miss out on that test at 3 weeks and just get the patient back at 3 months. And then you have the opportunity to do the serology. So the window period for syphilis, gonorrhea, I mean, the window period for syphilis, chlamydia and hepatitis B is 3 months. So we need to repeat all of those tests then. But I personally like to retest my patients at 3 weeks because there is about a 5% failure rate, and because I know that these infections, if they persist, can keep reinfecting partners. They're associated with pelvic inflammatory disease. I like to pick up the treatment failures.
Yeah. So if both partners have had their azithromycin and you're still showing up a chlamydia, do you give them another wallop of azithromycin? Do you change the drug?
Do a lot of contact tracing, because you wonder if there's a third party that hasn't been brought into the equation and discussed. And yes, I would retreat with azithromycin, and then very, very rarely you'll still get a drug failure, and then we would go back to treatment with the tetracyclines. And to be aware that there's more treatment failures in different parts of the body. So again, chlamydia in the rectum in men can be an LGV strain. So that's a special strain of chlamydia that affects men who have sex with men, causes rectal ulceration, and we've had outbreaks in Perth. We have also seen significant outbreaks amongst men who have sex with men in Europe and London, and they've also had reported cases in Melbourne and Sydney. And it's really, they've had to drive a new test for identifying this particular form of rectal chlamydia, because the treatment is with azithromycin, but for a slightly longer period of time. And the important thing about Path West is that they actually, if you identify the site as rectal, they will automatically tell you if it's an LGV strain of chlamydia. And again, if this is not diagnosed and people in the community aren't being tested for this, this is the strain of chlamydia that's a really old-fashioned one that used to occur out of Africa that caused the buboes, and they got the very swollen legs from infection. This causes rectal strictures, so we may see that in the future if we miss the diagnosis.
Okay, so this is going to cross over with gastroenterology as well?
Oh, there's so many crossovers these days. I'm now seeing more referrals from gastroenterologists than I have for a long time, because when they did their colonoscopies, they used to just go over the anal canal, but now they're aware that they're actually seeing anal warts, and so they're sending those patients to us now. And we've got a lot of crossover now with the colorectal surgeons. And in fact, one of the colorectal surgeons took one of these patients with rectal ulcers to theatre. They thought it was an anal carcinoma, but the surgeon was smart enough to realise that it didn't look like that and sent the patient straight up to us, and we diagnosed LGV and treated this very, very swollen edematous anal canal with antibiotics, and he got better. So it's important that people get tested and know the sexuality of their patients before they get taken to theatre.
Sounds like a great big improvement on a Hartmann's procedure.
Yes.
Jenny, the other thing that I often see in general practice is women with kind of, as you said, intermenstrual spotting and low-grade endometritis. And if you do a D&C or a endometrial sample, just a Papel sample, you will quite often get the pathology coming back as non-specific endometritis. Are we looking at any of these kinds of organisms there? Should we maybe ask for them to do a PCR on the curettings for this Mycoplasma genitalium or for something else?
I haven't seen any data at all where people are doing that, but I think now we know there's this new organism, and now we know that it's definitely a pathogen in men. I think we should be looking for Mycoplasma genitalium in women. We actually don't know where the best site is to do the test, but if you've got curettings, then you could do that. But whether a cervical swab is better than curettings, no one knows, and I've seen no data at all. So maybe you could do a little study for us.
Well,
and
maybe I could.
It could be very valuable. I'd like to hear what you find.
Now, Jenny, gonorrhea, you said on the up and up, nasty infections from overseas.
It was perceived to be mainly an infection in the metropolitan region that was affecting men, but now we're actually starting to see cases amongst heterosexual men and women. So there's been the crossover, and that's actually occurred, and we're seeing more and more cases in the clinics. So I think people need to be aware things are changing at the moment in Perth. And again, in the remote rural areas, then it's an infection that particularly affects the Aboriginal population. They have very, very high rates. It looks like the rates may be stabilising in some of those population groups, and there's intense resources being put into them. They've recently changed the guidelines in the Pilbara where they're going to treat with ceftriaxone rather than the amoxicillin and probenecid in the Kimberley region, and that's with azithromycin. But getting back to testing, I would plead with all of you as general practitioners, when you find a case of gonorrhea, to make sure that we actually get swabs for culture. We really do need to track the antibiotic sensitivity, particularly in the rural regions. I'm extremely concerned that if we get a highly drug-resistant strain in the remote rural areas and there's not enough testing, that we're going to see the comeback of untreatable pelvic inflammatory disease. If we get a drug-resistant strain, it affects the infants because it's transmitted at birth to the neonate, where they get the gonococcal eye infection. And even adults can get eye infection, and that's an emergency for treatment. So because it's so common, we have to seriously make sure that we actually do cultures so that we know what's happening in the communities and we can adjust the drugs, and if need be, call out a full-scale public health emergency if one of these ceftriaxone strains comes from overseas into a remote rural area. We don't want it infecting a whole community. We need to be extremely vigilant now. So when a patient's symptomatic, that's easy, we know what swabs to do. But if you're doing a test of cure on gonorrhea, then in women, we need to swab every possible site that could be infected. So we need to do a urethral swab, we need to do an endocervical swab, and we need to do a rectal swab. And people and a throat swab. And people are reluctant to do rectal swabs because they think it implies anal sex, but that's not the case. I mean, if a woman orgasms, she can get anal dilatation, the secretions can get in there, fingers can put them in there. So it's not a story about anal sex. What the physician needs to communicate to the patient is that the organism can just get in there of its own accord, and we need to find every place in the body that the organism's there so we can test to make sure the treatment works, because we know that we get more treatment failures in the throat and more treatment failures in the rectum. So we have to look at those sites and get rid of this embarrassment and just make it routine that that's standard sort of testing.
Some good advice there from Dr. Jenny McCloskey. When screening for sexually transmitted infections, the pathology results are only as good as the sample that's taken. We visited Perth Pathology and we spoke to the laboratory director, Paul Schneider, to discuss ways to ensure the pathologist has the best possible sample for investigation.
Paul, welcome to the program.
Thank you for having me.
Paul, from your point of view, at the lab end of the equation, what are some of the issues involved in making sure that you're getting a correct swab in relation to some of the sexually transmitted diseases?
Yeah, it's a sort of a multifactorial question. There is some confusion over what swabs labs actually require for their PCR testing for STDs. And a lot of it's based around that different manufacturers have their own peculiar swabs for their own particular method. And so from the requesting practitioner's point of view, they're going to have lots of different swabs with different coloured ends on them, so I'm not going to be quite sure what to have it. The most easiest thing to do is to clarify with your own pathology provider what swab is actually required. At the end of the day though, pretty much all of the laboratories will accept what's called a dry PCR swab, and that's a swab without any gelling. I've got some examples here. These are your typical MC&S swabs with jelly in the bottom. It's a transport preservative medium for routine culture and are used for wound swabs, ears and eyes and so on. A dry swab is same sort of thing, looks the same, but in the bottom there is no jelly, it's completely dry. And these are the swabs which are suitable for PCR for pretty much all laboratories. So the confusion is created by labs in that we have different methods for PCR testing. As I say, all labs will have their own particular swabs they would prefer you to use, but at the end of the day, pretty much all labs will accept a dry swab for PCR testing.
Now, you used to not be able to use wood stem swabs as well for PCR testing. Is that still relevant?
Yeah, look, it used to be in the days when, before PCR testing, or more appropriately nucleic acid amplification testing was available, that a lot of the methods relied on culture of the organism. And for some of the organisms, including things like herpes virus, the actual nature of the shaft of the swab could impact on the results and whether they're reliable or not. And certainly wood swabs were in some cases not recommended for viral culture because it was toxic to the actual cell culture. One of the advantages of the PCR methodology, which pretty much all labs use these days, is that it doesn't require the organism that you're looking for to be alive, to be viable, because it's actually detecting the nucleic acid of the organism. So if the organism is dead, it's okay, it'll still be detected in the methodology.
So then what about different sites? So taking anal or oral swabs?
With all the methods that the labs are using, I'm just speaking generally, they will accept swabs from the non-genital sites, and typically that's, as you said, it's the anal swab, it's a throat swab, and an eye swab as well. There is an issue in that pretty much all of the commercially available methods are not validated for non-genital sites, and so labs will still test for them, test swabs from those sites, but you'll invariably get on the bottom of your report back from your laboratory a disclaimer along the lines of this site has not been validated to MPAC requirements, and results should be interpreted with caution. What that sort of means is that at the end of the day, if you get a positive result back from one of those sites, you can believe it, but a negative result should be treated cautiously, and you should weigh it up with the risk of the patient.
What about herpes, taking a herpes swab? Can you just do it on top of the blister? Do you need to take the top of the blister off?
Yep, in the old days when it was viral culture was done as opposed to PCR or nucleic acid amplification methods, it was important to get into the base of the lesion as much as possible to get live and viable viruses. But with the PCR-based methods, it's less important because you're not looking for specifically for live virus, you'll detect dead virus as well. So as long as you can get any fluid as a minimum and any cells from the lesion, if you can get the top off the lesion and scrape at the base of the lesion, even better. But the advantage of PCR over the traditional culture method means you can now swab lesions which are even starting to recover, whereas traditionally you wouldn't worry about it with viral culture because there was no live virus left at all.
Right. So even down the track, you still get a...
Yeah, it's still worthwhile having a go at the swab if there's a discernible lesion there, because there could still be some genetic material from the virus still lying around.
Paul, talk us through first void urine and taking a good first void urine sample.
Okay, this is a common misconception with the terminology first void urine. Many people believe it's the first specimen of the day. In actual fact, it's not. It's the first portion of the urine stream. So from a lab point of view, the urine stream is seen in three components. The first portion, which is the first void urine sample, which contains the initial washout of the urethra with the lining cells. The midstream portion of the urine, the MSU, which everyone's familiar with, which is representative of bladder urine and is used for the diagnosis of urinary tract infection. And finally, the terminal portion of the urine stream, which really these days is pretty much only used for the diagnosis of a disease called schistosomiasis, and it's the last muscular contraction of the urethra which helps to dislodge the parasite from the urethral cells. So it's the first portion of the urine that we're actually looking for. It's important though that the patient hasn't voided for at least 1.5 to 2 hours prior to the test. So obviously if they've voided just recently, then they've washed out a lot of the cells and material there, so you're going to lead to potentially falsely negative results. and it's the first 10 to 20 mils, and it's helpful with the patient if you put a mark on the urine container so they know how much to fill it up as well. A lot of times we get asked the question, can we do the test on midstream urine samples, since that's the most commonly collected sample in laboratories. And where sensitivity is approaching that of first void urines for chlamydia, it's still a long way off for gonorrhea, so labs generally don't recommend testing midstream samples. They prefer first void urine samples for the best chance of diagnosing the STD.
And our thanks to Paul Schneider for taking the time to talk with us. Now let's return once again to our discussion with Dr. Jenny McCloskey and Dr. Olga Ward for any final thoughts and comments.
Well, Jenny, I'm sure I remember a little while ago you talking about doing rectal HPV testing as well.
The bane of my life. I've actually just finished a PhD on human papillomavirus in the anal canal. So what we're aware of now is there are groups of people in the population, particularly men who have sex with men and men with HIV who have a greatly increased risk of developing anal cancer. But in fact, if you looked at all the people in Australia, there are more women than men that actually get anal cancer. But it's the new area of research, and certainly women who've had cervical cancer or vulval cancer should get anal smears and be examined for pre-cancer. So we can
if
actually...
you've had a lady, say for instance, I've had a patient that I sent off the other week to have something that I biopsied as a VIN3, which has been excised. When she comes back for her pap smears, I should be doing a pap smear, a vulval smear and an anal anal smear.
Yes,
How do you do an anal pap smear?
Well, there's actually guidelines where the patients can do it themselves. That's one of the things. But we actually think that physicians may do it better. So just put in the cyto brush. The Americans don't like cyto brushes, but we use cyto brushes in our clinic, and just got to insert about 6 centimetres into the anal canal. So whenever a swab is inserted in the anal canal, it's like putting a proctoscope in. You have to angle it towards the patient's umbilicus.
Yep.
So
do this in the left lateral rather than in the normal lithotomy position on a bed, because otherwise you can't get the correct angle, or can you?
I actually examine all my males in lithotomy and females, and I actually had a new registrar in our clinic who watched me do it and said, Jenny, that is the best way of examining men. Now, the men don't like it, but the male patients are fine about it, but the male doctors have some reluctance. But when I talked to this doctor, what we found is that when you do so you need to palpate these patients to make sure there's no anal cancer. So you can often feel the lump, and that's the really important way of assessing them. So you need to look at the perianal skin, make sure there's none of those VIN lesions in the perianal region. You need to feel and make sure there's no anal cancer, and you feel their prostate. And if they're in the lithotomy, the prostate actually falls onto your finger, and you get a much better way of being able to palpate the prostate than in the left lateral. But until this new registrar discussed that with me, I wasn't aware of it, but it's actually true.
It's actually true. With women, I guess the same thing?
We do it all in lithotomy. It's just easier to have the bed set up the same way to do it, and you get used to putting the proctoscope in or the swab in, just angle it to the umbilicus. You just have to, once you've done a few, it's straightforward.
Okay, so basically anybody with a vulval cancer, that gives you a good inspection of the perineum, and you should be looking. Is that because the HPV is involved in vulval cancer, and you're concerned that it will reappear in the anal canal?
The data actually shows that those women who've had a vulval cancer, a vaginal cancer, or a cervical cancer actually have an increased rate of anal cancer. So it's treatable. The earlier you pick it up, the better the prognosis. So we really think that we should be looking for it in that group of women.
Okay. And finally, just on that point, do the gynecologists that we refer to for treatment of vulval cancer, will they do that sort of screening in the initial period?
I wish. It's an area that I think that I hope they will take up, but at the moment, mainly it's people who are doing high resolution anoscopy, and their sexual health physicians are driving this learning approach and raising the awareness of anal cancer.
Okay, so it would still be something that
disease.
perhaps the GP might need to screen in case the gynaecologist hadn't.
Yes, yes.
So we maintain that awareness.
Or if they're reluctant to screen, it would be reasonable to refer them to the sexual health service, because we're doing a lot of that at the moment.
Jenny, we might wrap that up there. We've had heaps of information this afternoon. Thanks so much for joining us.
We certainly covered a lot of material, thank you.
And that's all the time we have for this program. Thanks to all our guests, Dr. Jenny McCloskey, Dr. Terry Pitsakis and Paul Schneider. We're back on the 7th of May with the program on ears with Professor Harvey Coates. I'm Jerry Gannon. Look forward to seeing you then. Thanks for joining us.